Okay. So the first question you want to look at is why talk about efficiency? Um, it may seem obvious on some levels and then not so obvious on the other. But one thing's for sure, being efficient in surgery reduces stress to you, reduces problems for the patients. And the other thing that we got to think about in the future is they're making lots of people, they ain't making lots of more doctors. So we're going to have to become a very efficient delivery care system, and we need worldwide applications. So part of what we're looking at is what is a way to improve our daily routine cases, and how do we become better at dealing with cases in hard places such as Africa. So I'm always looking for ways of improving our skill set. So if we define the question is what is Phaco efficiency, and it's defined in many ways, but really what we need to do is we need to basically measure each maneuver that we do during the entire surgery. That's what we're going to do. I'm going to pass out this. We just started the studies because we just got everything completed. There's a number of these, so just pass them around, and that'll tell you what the study is going to include. And you're welcome to keep those and look at those. It might be interesting for others to kind of think about this in their own OR settings, or really analyze what each step that you do and look to improve each step. It's pretty amazing if you go back and watch your videos. You'll often you'll get clues as to what's going on, and you'll get an idea of how to improve your surgical skills. The other thing is to introduce new techniques, instruments, and look at machine parameters that can improve the outcomes. One of the things that's pretty amazing is if you look at many surgeons, and it's not a criticism because most of us do this, but you can almost tell when they graduated from residency by how they do the cataract, divide and conquer, whatever it is. And I think if we get comfortable with what we do, but there are improvements that come along, and I'm really happy that I'm lucky enough to know Taka, and his mind's always going, and it helps us introduce. Now, here's an example of just you say, what does this have to do with what we're going to talk about? This is okay. Let me go back. Let's go back one. When I was taught early on, what were we taught about INA? We would go under the capsule, grab a piece of cortex, and bring it to the center. But when you really analyze what's happening, look up here. I'm going to go back to that one little setting. If you look at the top of that, you'll realize that we're stretching the zonules as we're making that maneuver. We're pulling the zonules. So we were incorrectly teaching people to go to the center. And if you look at the tangential effect, very, very, very safe on zonules. But if you go to the OR and you look, almost everybody continues to do radial. They strip to the center. And so just look at, I want you to just look one more time at the top of that. Hopefully it'll show. What the heck? Nope, that's the next one. Damn. These new computers are driving me crazy. But look up here. So here's what we're teaching people to do. Stretch the zonules. That's an error. And as you look peripherally here and peripherally here, you realize there's no zonular stress whatsoever. So that's a simple example of why we need to keep changing, keep looking at times. The other reason to think about doing this is it is, one, obviously better on the zonules, but two, it's way more efficient. Now these are just some examples. These are not sped up. Because if you aim your tip not out towards it, but just stay at the top of the rexus and go all the way around, it's almost like doing your capsule rexus. Just go all the way around. And those are not, just a number of these. The other thing that I do that's different is I do a tear capsulotomy is how we were taught, but now I do a rip capsulotomy, which if you think of it, Taka does it all the time as well, I think. Basically what we're doing is we're doing an infinite number of Brian Little maneuvers. We're using rescue maneuvers all the way around, and what that does is that increases your movement, increases your ability to not have to move as much. So it decreases your time, and it's a way better to do the capsular rexus, because you're essentially reassuring that your tear doesn't go out. Every once in a while, obviously everything's a little different, but if you think about it, it really makes it a much more efficient way to do these. And you can repeat these. Now, the other thing that I realize now, and that I've changed lately based on the new technology, you see here I'm using a silicone tip. And I'm using a straight silicone tip, which is nice for for manipulations, a little tough for sub-incisional. And it's not the most efficient. The other thing that can happen with these reusable silicones is you get a nick in them, and you can pop capsule with them. So nothing's perfect, obviously, but so I've reevaluated this setting, and I'm now using a new ball tip that has been recently introduced by Phaco, and it's very, very efficient. Great for posterior polar, and because of its angle, which you'll see on the video, it's very safe or very easy on a sub-incisional. So one of the things we also, we get in a rut, and if we're doing, most cases, we think everything, this is the +1. All +1 cataracts are not the same. All +4 cataracts are not the same. So you have to be able to understand your parameters and maximize the parameters for improved outcomes. So what values can we modulate? We can modulate the IOP in the eye. That can either be done with active fluidics like the Centurion machine, or raising and lowering your bottle same way. And remember, if you're raising and lowering your bottle, the bottle height should be raised based on the patient's where the bed is, not the machine. Because sometimes you'll have a very tall person or tall surgeon, and their numbers are way different than other numbers. The next thing you control is the aspiration flow rate. If you want things to happen slowly, slow motion Phaco, such as say you have a very, very weak zonules, you're going to want to use a low flow rate. You may also at the same time want to modulate your aspiration flows. And how do you want to do that is something, if you learn the physics of these machines, that will help it. And then you can modulate the ultrasound power. So really, if you think about it, you got 3 things you're modulating. You could change all 3 every time. So you really have 27. And if you start individualizing within that power structure, you may end up with as many as 15, 20, 25 settings that you predetermined. Here's one for young kids. Here's one for miles. Here's one for a posterior polar. And most of the machines will do that for you. And then it's not then once you start the case, you could just say, hit my Phaco setting for posterior polar, and it's right there. And then you can modulate within that by telling them, okay, actually this one I want lower power, this one I want higher fluctuation, this one I want to change my power, my on time, off time. There's been a number of major studies. Within 2 months, there's going to be a meta-analysis paper that's been accepted that goes through all of the papers on parameters and looking at different parameters. And so I'd recommend when that comes out to really, take it, look at it, see how it fits within your practice. It will be in, it's in the, I believe, JCRS journal, and it'll be out in about 2 or 3 months. So I know about the paper because we worked on part of it. So, but we don't have it yet, but it is coming out. And then the other thing I would recommend is, if you have anybody close to you that does a lot of these, Bob Sione and I are partners, for example. So occasionally I'll go in and watch Bob, see what's he changed in the last 3 months. You're lucky enough to be in Taka, go watch him for a day and see what he's done, see what he's altering to make his life better, his patient's life better, and that'll ultimately make you much more comfortable as well. The other variables that we all need to think about are Phaco tip design. The Phaco tip can have a dewy component to it. That means that the edge is not a good cutting tip, but it's kind of safe. It's good for soft cataracts. You can get fairly close to the capsule it doesn't cut the capsule because the tip is rounded, but it doesn't cut. Bent tips, a number of studies have shown that when you look at bent versus straight tips, kind of depends on parameters that you're using. There's not a huge difference between the two. We've always been taught that the Kelman tip, the classic Kelman tip, delivers energy much more efficiently than a straight tip, and it turns out that it's not just the design of the tip; it's the modulation changes that you make. You can make every one of those easier. You want to get something that's comfortable. I happen to like reverse Kelman tips. I like to use the harmonic tip that Taka has just recently introduced, and we've been using it in Utah in the study but also in Tanzania. INA materials and tips are also different. You have silicones, you have polymers, you have ball, you have metal tips. So again, and one of the things that's different with each of those is the hole. Some of them are 0.3 millimeters, some of them are 0.2 millimeters. So that changes you can't, if you change your INA tip, and your previous parameters were set for a 0.3 tip, then it's not going to be as efficient. So again, you have to know if something. A lot of times, reps will come in and they'll say, "Oh, here, give this a try," and you'll say, "Oh, this is either great," or you'll say, "God, it didn't work I couldn't get it to work." It may not have been the tip. It may have been that the tip and the parameters that you were using were not appropriate for the new size of the tip. And the smaller the INA tip, better grabbing, but takes a little bit longer to do your aspiration usually. So there's a plus and minus with all these new variables. Also, power modulation is really critical to understand. Most of us were taught, well, actually I was taught, since I started in Phaco in about 1977, we had only on and off. We had zero, there was no modulation. It was 0 or 100%. There was, and about 5 years later, you got some power changes, and then on and on and on. So now we have just great physics, great abilities to change, and there is certainly a difference between continuous and torsional. Every once in a while, every once a month, every Friday at my house, I have the residents over for beer and pizza or juices, whatever they want, and we watch their videos. And the first week, I bring all the fellows from other programs, and I ask the fellows, why are the videos there? And I'll say to them, why are you using these parameters? And what are you telling the machine to do? And almost none of them can tell me that answer. I say, when you sculpt, what do you want the machine to do? Do you want no occlusion, slow hand, lots of power, whatever it is? Because they're not thinking of the physics of the machine. And the more we understand about the variables and what we can do, I think the better surgeons we're going to do. And pulse is interesting too. Most everybody trains in a continuous mode for most things, but pulse is really valuable because it decreases the energy, but it also increases the efficiency depending on the on and off time. And that varies with the hardness of the cataract. So if you go back to the possible 27 things, we're now adding a number of variables. And I can't even imagine, I mean, if you really think about it, there's probably 200 different modulations you could change. But if you understand the basics, you can change it on the fly. Because sometimes I have a set setting for what I think is a +2 cataract or +3 cataract. And I had made a mistake in the clinic, and it's a 4 cataract. So you need to know that it's not going to be inefficient. You're in the wrong modality to do them. So it's worth looking at that type of modulation. So what we're doing at the Moran is, Robbie from Masico here introduced me to Taka's brand new designs, and I think you're following me, right? Should be the other way around. You should be teaching so I can learn, but no, I mean, but at any rate, what they are is ways to improve your efficiency. And I've been using the chain cannula for 10 years or whatever. I've switched to the Akahoshi because I get better hydrodissection. It's easier. I have not had a failure with it. I mean, it's hard to say, well, how many failures do you have with a Chang? Not many, but this, again, this has made it significantly easier for me, particularly when I'm teaching residents, because they often don't understand tilts and things like that, and it's really designed in such a way that it makes it easier, and I think you'll show examples of that much flow. So those are important. The other thing is we've designed. Well, yeah, go ahead.
How does the new Akahoshi hydrodissector vary from the old one? I used the one that's been around for a long time. What's the difference with the new one?
The tip is tapered. Bent and tapered.
Tapered, yeah. So the taper, I think, is what makes it, and you don't need as much, you can use a 1 cc, 2.5 cc. Most people use a 5, it's okay, but you don't really need to do that because of the tapering aspect of it. And if you look at all the other, they're not that way. Most of the cannulas are not that way. And so what it does is it allows you to get into the space predictably, and you because of the tapering, you don't have to push hard. You get this beautiful flow, so you can just slowly watch it, which is fabulous for hard cases. Because once you get used to it, a lot of times when you're doing a +5 or whatever, you can't see that flow. Here you can see the lens come up very easily, slowly, controlled, so you're not disturbing zonules. It's really makes a difference. So it's a subtle change, and again, you put them next to each other, and you might say, oh, there's not much difference here, and it's right, there isn't. But there's just a little engineering that makes it more efficient. Yeah. And a couple of new pre-choppers, I won't go into their design because I think Taka will probably enlighten you better on those than I. But what it did for us in Tanzania is when we do these missions, the week before I was in Tanzania, I was in South Sudan. Now, South Sudan doesn't have enough power to run a Phaco unit, number one. And number two, most of the eyes that we dealt with had trachoma scars. So that's all SICS. We didn't, there's no way we could have delivered. We ended up with about 600 cases in a week, 2 of us. And if you're not doing SICS, you're not getting through those. So we sent people in to evert the lids, trachoma-wise. They did that a week before we did the surgery, and then we did the surgery. But then I went to Tanzania. In Tanzania, you have mostly clear corneas, but access to care is poor. So most of the cases that came in were quite hard. Usually listed at plus, depends. If nobody, it's all individual unless you're doing a study and you happen to have the pictures right there. But certainly none of those that we dealt with would have been under, a 4, because to get in you had to be bilaterally blind or bilaterally at least at the 2400 level. So they were, and as far as we could tell, normal tips. And then then again, the tip designs, which could be reverse Kalmans, straight Kalmans, sharp tips, Dewey tips, Packard tips, and many of these also have different diameters. The Packard reverse Kalman from MST is 0.9. It's small, and its flow patterns are going to be way different than the harmonics tip and some of the other tips. So that's why I think it's important for us all to really get a good idea of that. And I do happen to have that Akahoshi, so you can see it as it passes around. I couldn't get a picture of it. So here's some of the new instruments that we're dealing with, and I will let talk about the specifics of it. But you can imagine, if I can get this, I don't know where my thing. See if I can get a spotlight up there. Well, at any rate, this one, I don't know why my thing's not working. This one, as you can imagine, they're both sharp, but the design of that is that it can go in way easier in a hard cataract, but they both have different techniques. So I have 3 or 4 different pre-choppers for the density of the cataract. A soft cataract is almost not worth pre-chopping. You can try, but it just splays it apart. What I'll often do, depending on how hard it is just start it and then reverse the paddle so the rounded part is towards the capsule, and then you can go in and you can get it spread apart. But it's not very efficient, and super hard ones are not. They're not very efficient. There you need pre-chopping, or not pre-chopping. You need Abe Vasavada's technique of multiple chops, or variation of vertical chopping versus horizontal chopping for those, which is really not part of this discussion. But the new ball tip. One of the things that's always difficult for my residents is subincisional, and also to understand that they really want to be at the top of the rexus, not at the bottom of the rexus. When they go, they tend to want to slide across the posterior capsule, grab the cortex, and bring it to the center. And that's not very efficient, and it's not safe on the eye. So what this does is it's ergonomically set up so it makes that a very, very simple maneuver. So I think it's worth looking at for sure. And if you haven't pre-chopped, I would say, one, get some videos, look at the videos, or we've done 20 years of courses, right? And now we have 32 people who are, for whatever reason, they go home and they don't do it. But I really encourage you. All our residents do it, and they all go out and buy the instruments because it's such an. If you think about it, you can pre-chop with this machine, with this, or if you want to use a MyLoop, I don't care. But the MyLoop is a lot more for harder cataracts, but also it is a single-use device. Whereas these are, these last years. They're much better from that standpoint. Okay, so just to give you we don't have good video in Tanzania. Half the time it's totally out of focus, and at least 5 times during the morning in the OR, the videos, the entire electricity goes out, That's one, and so they have to boot all these things. So we've lost some of the stuff. So I'm just going to go ahead to the action here, and also it's not coaxial. So here's the use of the Akahoshi. You can't. This is a hard cataract, relatively hard cataract, so you can't see very well to the back. And I know from our course on Saturday that Taka's going to show you some rocks that he's able to get with this instrument. But I've been going there for about 10 years, and the difference this year is that we were able to, and we're transferring Phaco techniques to the local ophthalmologist for cost recovery. But you can see here, this is just a slow downward motion, and you get a beautiful crack, and you get that type of a crack in just about every case you do. You have to enter slowly, and most importantly, enter right at the center, so you get the sharp tip going down, and then spread out. And then this is using we use an Ortley machine over there. Now, an Ortley machine is fairly different from the other machines, except they're all the physics is the same. The beauty of the Ortley machine is it doesn't have to be rebooted when the power goes out. It's designed for this kind of travel. So we have 6 of them, and it helps. But we were timing the amount of Phaco power. We had no overlays, obviously, because Ortley does not have an overlay. But we were able to go up a full grade. So instead of just doing 3s, and then on 4 and 5s going to pre-chop, to SICS. My 200 cases, 90 were SICS, and the rest of them were Phaco, and they were the pretty hard cases. And you can see, you can't measure the fluid here, but this is the sustainer that you can use. But the machine is very, very efficient. We have to go a little slower in theirs because the flow pattern's different from what you're used to, but not unlike that. And so in the whoops, let's go to shut. Play. Sorry about that. So I would obviously sped it up to the Rexus, and that's done. And I should have left on the marker. So I use the new combination. It's got a marker, which you can see here for the cornea, and then instead of putting it back and handing it, and since we're doing a study, we're measuring. These are going to be 2.2s for my studies, so that we can make sure that we're getting no outflow. And then you'll see here's the, let's speed this up. The pre-chopper comes in and measuring different lengths. And that's the new hydrodissection piece. It's just, this is a resident doing this case, and you'll see how it gets a nice flow. And over here. And we use very, very nice, I don't know, it's not a rock hard, obviously, but you could see the flow, the dissection behind there. It's very, very efficient. And we have not found it to be, so we've switched all of our people. This is another variation. This is one that we're also looking at, but it's the same design. Very thin, very sharp. And the beauty of pre-chopping, in any way you do it, I want you to think about it, how much fluid do you have in the eye? None. So you can get your nucleus into quadrants, 6 pieces. If you get hungry, you want 8 pieces, you can do it. And you have the hardest, one of the hardest parts of anything, of phacoemulsification is getting the quadrants. And what this does for us internationally is it allows us to reverse teach folks about Phaco. What do I mean? Everybody here knows that there's no inconsequential step to Phaco, right? A bad incision, a bad stab, a small rhexis, all of that interferes with it. And when you're trying to teach someone, it's cumulative. And the hardest part of Phaco is the groove, teaching someone the groove. So what we're doing is getting them they're getting it into quadrants, and then we can teach them the necessary tools, understanding the fluidics, because it's already it's already broken, and we've used no fluid during that case. And then the other thing we'll do is over here you'll see, which is when we get the whole study done, we're planning on about 400 patients, so it should take us about a year to finish the study, and because not all patients are eligible for it, and then we'll look at different time on, different time off. If you do burst modes or we have torsional and longitudinal and short times, and there are multiple studies out there that show that it doesn't make a huge difference about the time on, time off in so much in torsional, but it does in longitudinal. And it turns out that this is probably too short of a time right here for different kinds of cases. So we've got a long ways to go to really see what's usable. And because this was a resident case, we used the standard tip rather than my new favorite, which is the Akahoshi, the new Akahoshi tip. So and changing parameter times and all that, because we want them to understand the physics of what they're really doing. So we've got the study's beginning. We're about 2 or 3 months in, and we probably have 15 patients. But you'll see here as we get at the end of this step. See, and I encourage everybody to kind of look at their own stuff. You can see what's going on there. So every time if you just have your technician hit the CDE on the top, it will give you all these numbers, and you can see we've only used 27 cc's of fluid. Now, with Aka's tip and me doing the case, we're probably down to 17, 18, 19 cc's. And many cases, total case with INA and everything, were around 70 or 80 cc's of fluid, which is good for the endothelium, obviously. And if we were in a space where you could reuse the bottles and all that stuff, it would be very cost effective as well.
What size side port incision do you use?
I use a one. You could, I don't. It depends on what, like your second instrument is. Some of them are a little bigger. So it's just a matter of what works well for you. Whoops, I'm sorry.
With the Centurion, you use a 2.4?
I 2.2. Yeah, at the private hospital with Sione and I, it's 2.2.2.4. So internal, once you reach the internal is 2.2, the external is 2.4. Actually, what you'd really want is the opposite. You'd like to have it 2.2 and then internally 2.4, so your internal manipulations are easier. So I use a 2.2, and then I widen those a little bit depending on the length of the strength of the.
Which catapults are you using to
This is the new combo. Do you have the number for that? Do you have the number for the combo?
The new combo 4 is 41 meters.
So so it has a marker on it, and then you just reverse it, and you have it's the same one. So it's very efficient. And there's 2 models. One's curved and one's straight. And then,
Which one do you use? The curve?
I have both. I'm evaluating to see which one. The residents seem to do better with the curved. I like the straight, but it probably doesn't make a difference. Yeah. So that's a little bit. So, and I guess the point of what I'm talking about is really we're at a point now where we are developing great great care, and we wanted to be efficient, and our patients are living longer. So the least amount of energy we can use to fix an eye, I think in the long run may turn out to be valuable. And it also, I think these kinds of things make pseudoexfoliation easier, dealing with other types of pathology easier. So I would just encourage everybody to look at their data, and it's something we often don't think of. You know what? This is a +4. I need this setting. I need setting 20 or setting 16. I just keep 27 on because we have other surgeons, and that way it gets too confusing, you know, who's in what and doing what stuff. So, but the more you understand about that, I think the more comfortable you'll be. And these new tools, you know, you don't run into something that is really advanced the surgery and made it a lot easier, and these do. And I've been around a long time. I'm almost, no, not quite. So, well, thank you for your attention, you guys.
Tell Marco who she is present at 11 o'clock.